Well, welcome everyone, and thank you so much for joining. And we hope we are true to the hour that you have given us because this is an important case, and it's an important case for several reasons. One reason is because it's a case that can so easily deceive us. I had a patient just recently who came in, they were caught shoplifting and they had chest pain. And the nurse, in very uncertain terms, told me it was not because of acute coronary syndrome. It was because they got caught shoplifting. But as we all know, in a career where we see 100 to 150 or 175,000 patients over 30, 35 years, well, we're going to have those kinds of cases. And it's good to be usually right, but it's even better to be all right. So what I want to start with is just making sure everyone knows that there are no disclaimers as far as any conflict of interest. And I wanted to make sure you also knew that you can get CME for this. So you can get 1 hour of free CME. Here is the QR code for that. And I'll just have that up there while I'm just letting you know. A very exciting thing tonight that we have over 200 participants and participants from 36 different US states and 8 different countries. So very exciting. And anytime that you want to sign up for these critical care book clubs, you can do it from the links that you get off of Twitter or the emails that you get, but also the website, embouncebacks.com, has links to sign up. So here's, again, that QR code for folks who missed it to get your 1 hour CME credit. I will put that up at the end also, so there will be another opportunity for that. So with no further ado, want to introduce our all-star panel here. Tim Montrief has been on here before. He is EM Critical Care Assistant Residency Director, University of Illinois in Chicago. Mike Pallaci, who has been on in the past several times, Professor of Emergency Medicine at Northeast Ohio Medical University and an adjunct clinical professor at the OU Heritage College of Osteopathic Medicine, as well as core faculty at SUMA in Akron. And we have Nicole Tyczynska, and Nicole is a attending physician, Department of Emergency Medicine, Our Lady of Lourdes Medical Center in Camden, New Jersey, as well as a clinical assistant professor at Thomas Jefferson, as well as George Willis, who you have, I'm sure, heard in other programs, Associate Program Director, UT Health Science Center in San Antonio. So welcome, everyone. Thank you so much for joining. We were talking just before the program started. I feel like a slacker because I think everyone else worked an entire shift today except for me. So you should be very well practiced in emergency medicine with the answers that you give. So let me go ahead and just introduce this case. And this is a real case. The documentation, the actual documentation, nothing has been changed. There's no HIPAA disclaimers or anything like that. Obviously, the patient's name is not on here, but it's a 59-year-old man who presented to the emergency department, and this is how his initial visit was documented. And I'm not going to read the whole thing for you, but just the important points, and I've highlighted this here. So 59-year-old male presents for medical clearance after being tased. He's complaining of severe back pain, writhing in pain, states he has difficulty speaking or taking a deep breath due to his pain, denies medical problems, felt fine prior to the taser application. And as you go through, you'll see his vital signs are, as I'm sure you'd expect any of us would be after being tased, a little bit elevation in his blood pressure, but the rest of the vital signs actually look pretty good. His physical exam, interestingly, well, we'll talk about that in just a second here, but his physical exam is as you see it. He had a chest x-ray. The ED course said that he's sleeping comfortably, vitals are improved, and the medical decision-making note, and I'll just summarize this here. 59-year-old male with pain, subjective shortness of breath, taser application, satting well in room air, chest x-ray normal, lung exam normal, improved during his stay. So what I wanted to do is start off with some thoughts from our panel here. And I know, folks, we haven't really incredibly planned this part. I just wanted to get a little bit of thought. Mike Pallaci, you are the chapter author for the documentation chapter in the Corpendium online textbook through MRAP. What is your thought on this documentation? If you could just give us a bird's eye view of that.
Yeah, I mean, there's lots that I could say about this documentation, Mike, but we only have an hour, so we'll try and just. There's three key points that I'd like to make. First is they note this severe back pain, and they even note that the patient is writhing in pain, but there's really no documentation about whether there's any red flags for the life-threatening diagnoses. And that's, for something like back pain or even like headache, where we see it's frequently benign, but there's a few can't miss diagnoses that are that are hiding in the weeds there. It's really important to think about what are the red flags that would make me think of those diagnoses, and to document that they're not present, and that wasn't really done here. Second, you mentioned the blood pressure. Like, obviously not every elevated blood pressure needs a workup, but it does need to be addressed, and it's not really addressed. I don't believe it was repeated before discharge. So not intervening on elevated blood pressure is fine, but you need to document that there's no acute end organ damage. And then finally, the medical decision making is not supposed to be just a restatement of the history and a restatement of the test results. It's really supposed to be, you've always said it, it's a hard stop prior to discharge, where you articulate your decision making, your thought process, you put it down on paper, or in this case in the computer, and then you ask yourself, does this tell the story of why I think it's safe for this patient to go home? Now, they said that they improved during their stay. Well, how did they improve? They don't really know. Did you consider other life threats? If you did, how did you rule them out? I mean, it's okay to say I'll rule them out by H&P, but there should be a thought process in there. So the medical decision-making section, as is frequently the case in these bounce-backs cases, I think is a little bit lacking.
That's fantastic. I'm going to add one on to you, as long as we're piling onto this physician who is not here to defend himself. And I will tell you this, as a third-year medical student, got a little bit of a tongue lashing for this exact case of myself. Not this case, but in the same sort of way. This patient has back pain, and there's no back exam. And I, in a self-deprecating way, as a third-year medical student, gave this hour-long, presentation of this patient with, 8 generations back in their family history. But the patient had back pain. I did not really examine their back. So, man, I get it, how easy it would be to do that. But really, objectively, I mean, this patient has back pain. So, Nicole, you have sort of prepared for us just a very brief, 60, 90-second, maybe a little bit longer discussion of really breaking things into mechanical versus non-mechanical back pain. Look, I know there's a lot of expertise on the call here, but why don't you just sort of at least give us a little bit of a differentiation to that, because obviously that thought process did not occur in this situation.
Definitely. So, I mean, I don't have a shift that goes by that I don't see a back pain patient. So I think all of us are pretty well versed with whatever our stepwise thought process is for our back pain patient. And the truth is that most back pain we see in the emergency department, it's going to be mechanical. 97% of these cases are mechanical, with most of them being in that lumbar strain category. That's about 70% of them. Everything from slipped discs to overuse injuries. Only approximately 1% of them are going to be traumatic. And actually, in this patient, my first thought would be in what you had said, documenting a back exam. He got tased. This guy might have fallen down. Are there bruises on the back? Am I worried about, they get a chest x-ray to rule out rib fractures, which can be a cause of referred back pain as well. So I think that was definitely lacking in their thought process of the traumatic aspect of mechanical back pain. But then when you kind of look through all the non-mechanical reasons, that actually opens up a whole broader differential when you're thinking non-mechanical, which we also have to think about. So when I think about non-mechanical back pain, I think about all the different ways that back pain can be referred. So is it back pain that's being referred from another joint? Is it something more visceral? Am I seeing back pain, but really I'm dealing with something GU, like a prostatitis and endometriosis? Any woman that's ever been in labor knows that uterine contractions go to the back. So definitely a lot of visceral organs can transmit to back pain. You have to think vascular. Huge blood vessels go through the chest right along the back. So is this a AAA? Is this a dissection? And then other systemic things. Actually, the number one cause of non-mechanical back pain is unfortunately neoplasms. So is this a presentation of a leukemia, lymphoma, a multiple myeloma? Is this metastases? Or does this patient have some other autoimmune or inflammatory cause of back pain? Are we seeing symptoms of back pain that are secondary to their autoimmune condition? So hugely broad differential, and we're running through this all super quickly in our heads while we're risk stratifying these patients. But I think, like Mike was saying, red flags. I always ask about IV drug history. I mean, I work in Camden, it comes up. IV drug history, definitely, but also weight loss that was unintentional. Does the patient have a history of cancer? People will be forthcoming with that. Are they immunocompromised? Is there any chronic steroid use? Those would be kind of some of my big red flags.
So that's awesome. And, the thought process about all those things is easily to be led astray, right? When a patient comes in after being tased. And then the question we have is, are they just sort of saying that because they don't want to go to, jail to prison to be arrested? Or could something else possibly be going on? So it's always incumbent upon us, right, to at least do that cursory or hopefully more than that evaluation of at least the presenting complaint, right? And so, George, interestingly, I know Mike had a little bit of criticism of the medical decision-making note that it wasn't really the medical decision-making note. It was more just sort of stating what they thought the test results were. For example, the chest x-ray being normal and the lung exam that was normal, sort of restating what they'd already said. But interestingly, after this patient left, the documentation of the chest x-ray was a little bit different from the radiologist. I'm just going to read to you, George, what it says. The chest x-ray result says, and interestingly and sort of concerning, possible ascending thoracic aortic aneurysm. And when you put that in there and the possible in front of it, and especially if the read comes in after you've already finished seeing the patient, obviously this is a huge medical legal risk, and hospitals as well as our emergency departments need to have some sort of mechanism, for x-ray discrepancies. So George, why don't you walk us through how we even decide if a mediastinum is widened, and then if that is the case, what are the potential causes of that?
Sure. So first and foremost, one thing that you have to make sure of is you have to make sure it's an appropriately done chest x-ray. And a lot of times, especially in this era of COVID, we were getting a lot of these portable chest x-rays. X-ray techs didn't want to go into rooms and shoot x-rays on people. So we would get these very inappropriately shot x-rays and base our medical decision on this. So you want to make sure it's an appropriately done PA chest x-ray. So in that circumstance, with an appropriately done non-rotated upright portable, PA chest x-ray, if you measure across the mediastinum, if it's greater than 8 centimeters, it is a widened mediastinum. The most common cause of a widened mediastinum is a poorly shot chest x-ray. So if you have an appropriately shot chest x-ray and that mediastinum is greater than 8 centimeters, then you certainly should be thinking, what is the cause of this patient's widened mediastinum? And there's a lot of things that can cause a widened mediastinum, and I can't tell you how many times my residents will come to me and say, hey, Dr. Willis, this person has an aortic dissection. Why? Because he has a widened mediastinum. First of all, why did you get a chest x-ray when the patient's coming here for groin pain or toe pain?
Right.
So in the setting of a person who has a widened mediastinum on a chest x-ray, the things that you want to think about, obviously Monday morning quarterbacking this case, you obviously want to think about, could this be something wrong with the aorta? Could this be something wrong with the mediastinum, such as mediastinal lymphadenopathy, which is another very common cause of a widened mediastinum? Malignancy is another big cause of a widened mediastinum. So there could be mediastinal masses, there could be some type of cardiac malignancy, lung pathology, lung malignancy that can cause a widened mediastinum. Some kind of more rare cases would be someone who has a retained thymoma. Most of the time, the thymoma will involute as you get older, but some people hold on to their thymus gland and it becomes enlarged, and that can cause a widened mediastinum. Some other things, mediastinal lipomatosis, which is actually some fat tissue that gets into the mediastinum and just stays there. Most of the time it's non-serious and very benign, but it's just another thing that can cause a widened mediastinum. And then in this scenario, you have a patient who sustained getting tased. I'm envisioning when I've seen people get tased on television that they fall, they have trauma. So this patient may have fallen forward and hit his chest. And if he broke his sternum, you can actually get a hematoma behind the sternum, and that can also cause a widened mediastinum. So there's a lot of different things that can cause a widened mediastinum. Obviously, being emergency physicians or providers, the most common thing that we're going to think about is aortic dissection. But in this circumstance, you have a patient who has an abnormal finding. You now have to find a way to explain that abnormal finding. And certainly calling it normal when it's not normal is certainly the wrong thing to do.
So George, I'm going to take you to the next level, a little bit of a harder question here. So you see a patient who, like, you would bet almost like your life that this guy just being tased doesn't just happen to have a thoracic aortic dissection. On the other hand, you have this X-ray report, which is saying something that doesn't go along really at all with the patient's presentation. What would you do? And I'm going to give you just a couple choices if you were the emergency clinician at this time. One is say that it was an AP film. You get a PA film. It shows a totally normal mediastinum. You're good. You let the patient go. Do you automatically go ahead and order a CTA with a dissection protocol? Or do you do some sort of follow-up with this patient, again, who you wouldn't really otherwise expect that you have this finding?
So this is a great question because there's obviously a lot of things. Again, it's hard not to Monday morning quarterback this scenario, but you have a patient who has abnormal vital signs. He has acute thoracic pain. And I always tell people an aortic dissection is the thunderclap headache of the thorax. Somebody comes in with acute onset, any severe pain in the thorax, you have to rule out in your mind an aortic dissection. So you have this person who now has an elevated blood pressure, acute thoracic pain, and now you have an abnormal chest x-ray. It would behoove you, you would almost have to convince me, like the patient would have to basically refuse to get a CTA for me not to get a CTA in this person. But if it was an inappropriately done study, if they shot a portable AP and the patient looks really well, and again, let's say they didn't have a story of acute thoracic pain, they just have a little elevated blood pressure, they have this widened mediastinum on the AP film, I would absolutely shoot a PA film if I was not really suspicious and I said, wow, his mediastinum looks a little wide, I probably should get an appropriate study to make sure that this widened mediastinum is not just the technique that they use for the chest x-ray. And then if the PA film was appropriate, then I would absolutely discharge the patient. If it showed another widened mediastinum, I think it behooves us to image that aorta and make sure that that aorta is in appropriate dimensions.
Yeah, and I'll tell you, some of the ones that I've caught is lack of an alternative explanation. So if you pull the patient's shirt off and you see like he has localized tenderness right over the area where the taser hit the skin, just for example, well, I mean, that's a little bit of an argument for that. But yeah, I mean, his radiology report is sort of asking that question. And like you're saying, George, you really have to convince us not to do the CTA as opposed to have a reason to do it after we've already gotten that report back with this patient's at least severe pain, as he's saying. So Tim, kudos to you for being super patient for this whole time when we've all been talking about stuff. But what I want you to do is to bring this, like wrap this in a basket, put a bow on it. Where are we at before we get this bounce back and some of the critical care aspects of the presentation tonight that we're going to talk about? Bring this all home for us. What can we take away as far as this initial evaluation?
We have a gentleman who is pretty high risk in terms of abnormal vital signs, some very concerning imaging. And then on the other end, the history of, I just got tased and trying to marry those two together and bringing together what Mike said in terms of documentation. If you're going to say, hey, I think everything's normal, then you really need to make sure that you have a complete history, physical, and you're documenting appropriate. And if you don't, and you think that it's pretty suspicious, like George, then you got to go and you need to work that patient up, right? So when I take a look at this patient in the emergency department, I say, if this person didn't come in and he wasn't tased, but he came in with the exact same presentation, what would I do? And usually I'll let that answer guide me.
I love how you say that because, again, Pat Cross-Carey's cognitive dispositions to respond are the things that can certainly lead us astray. The fact that this guy happened to be tased, right? And look, I get it that it makes it less likely something serious is going on, but thinking about it in that way, he has the presentation, skip the taser, skip the argument with the spouse, skip whatever other thing that could distract us. Now let's just evaluate what's in front of us. And that makes the decision. So it sounds like what you're saying is you agree with George. You have this exact same patient in front of you, Tim. You're getting the CTA dissection study.
100% of the time.
I was sort of hoping we'd have a little conflict here and you disagree with George. Not
Maybe
really.
later on, if this patient bounces back and there's management issues, George and I can get into it.
All right. All good. So let me tell you what happens is the patient goes home, and interestingly, there's not a bounce back in 1 day or 2 days or a week or a month even, but interestingly, 11 months after the initial visit, the patient returns. And I know we haven't really talked about it a whole lot, but this patient does have a history, that was in the title of the discussion here, of meth use. And we've all seen plenty of meth patients, and the center that I work at has a lot of meth. And patients come in, and you can almost just sort of tell by their emotions and the way they look that that's what's been going on. And this patient did, when he returned, say that he has now abdominal pain mid-epigastric as well as history of meth and alcohol use. So I'm just going to, again, very briefly summarize things. The patient came in with upper epigastric abdominal pain, non-radiating, has been constant since the onset, began at 8 o'clock, and here's now only 9:45, so pretty soon after the patient's pain started. And I know he says he denies had the previous meth use from previous, but anyways, that's part of our history. So anyways, short version is the physical exam you can see in front of you. The vital signs actually look similarly okay as to what had happened in the past. And on his abdominal exam, he had some tenderness in the epigastric area. And medical decision making, uncomfortable appearing 60-year-old male with acute onset of upper epigastric abdominal pain, vomiting, exquisitely tender upper abdomen left lower quadrant, interestingly. And they say the differential includes gastroenteritis, appendicitis, cholecystitis, diverticulitis, doubt acute coronary syndrome, or a abdominal aortic aneurysm. So Nicole, why don't you guide us through where we're at differential diagnosis at this point with epigastric pain, and then what we're going to do is going to get into what the actual clinician did and how, again, they got a little bit led astray with some of the findings on the test results.
That differential sounds like somebody dropped a dot phrase, because how are you fitting appendicitis? Not to say that appendicitis isn't the masquerader of masqueraders, but so what am I thinking with this patient? So I know he's got methamphetamine and ethanol use history, and he's very uncomfortable appearing, and he is super tender in his epigastric. So one of my first moves is going to be an upright chest X-ray, because I'm thinking this guy probably has, at the very least, a history of alcoholic gastritis, maybe peptic ulcer disease, and I'm thinking a perfed viscus, like a perfed peptic ulcer. I'm also thinking right along that top line, I'm thinking pancreatitis related to ethanol use, and I'm thinking maybe some liver disease. We'll throw in a lipase hepatic function. So definitely in that category, I'm thinking. I'm also thinking, well, methamphetamine use, he's older, he's in his 60s. I'm going to get an EKG, and I'm going to rule out any kind of acute coronary syndrome or any other sequelae of his years of methamphetamine use in terms of an arrhythmia, what have you. Finally, I'm a little bit perplexed by this left lower quadrant pain. It doesn't necessarily fit with everything that I'd like to put in that upper abdominal quadrant workup. So that makes me think of something that's going to link your upper abdomen with your lower abdomen. And what does that? Well, you have to consider in these patients, especially people who have lived their lives doing a lot of drugs that cause sympathomimetic toxidromes. Is this something vascular? Are we dealing with a dissection? Are we dealing with an aneurysm? So yeah, definitely upright chest X-ray would be one of the first things, EKG, and then sending off labs.
Yeah, and we've all seen those patients who have maybe some pain or maybe not that much pain. It turns out to be inferior ischemia, right? And that presents as epigastric pain. So certainly not only thinking of intra-abdominal, but areas around that too. So I'll tell you what the provider actually did. They got a EKG, and at this point, the patient was tachycardic with a rate of 117. I think the initial EKG or the initial heart rate was only 70 here. So they did not see any ischemic changes. They gave the patient some fluids and some ondansetron, as well as some morphine, and they got a bedside ultrasound, which showed some pericholecystic fluid, gallbladder wall thickening, and they say in their MDM at this point of the evaluation, worrisome for acute cholecystitis. We'll order a formal ultrasound. They got some labs showing, maybe a little bit of a bump in the white count, and then they went back and looked at the records and found that the chest X-ray read wide and mediastinum. Mike, first of all, can you help us out with what is the sensitivity and specificity of a bedside ultrasound for something like cholecystitis? And the next question is, this is pretty weird, like a widened mediastinum 11 months previous, and now the patient's coming back. So I want you to sort of focus on that ultrasound result, then we're going to go into some of the mediastinal stuff in just a few minutes.
So the, I can't give you a great number on sensitivity and specificity, Mike. You can find some studies that will quote it, but there's a lot of variability in the studies, and really gallbladder, as much as any other indication for point of care ultrasound, gallbladder is very operator dependent. So it's really going to be dependent upon the skill of the person who's operating the probe. That being said, even in the best hands, sensitivity and specificity for this is far from perfect. So there's a couple of things that are a little concerning to me here, in that first, there's no stones. Now, acalculous cholecystitis does happen, but it's not very common, and it tends to happen in people who are super sick, whether they're septic or they have cancer, or maybe in a post-op patient. So acalculous cholecystitis in the absence of any of those things would be pretty uncommon. Really, I wouldn't expect that. There's no sonographic Murphy sign documented. That's actually the most sensitive sign for cholecystitis. So if they have cholecystitis, a sonographic Murphy really should be present, and that wasn't indicated. Does the history fit? I mean, were the symptoms postprandial? There's some other things that could be addressed there, but most importantly, gallbladder wall thickening and pericholecystic fluid are not at all specific. Okay, so if you find them, that does not mean that you have cholecystitis. That can happen with mesenteric ischemia if the gallbladder is ischemic. That can happen in cancer patients. That can happen, a variety of other things. But the idea that you have a thickened gallbladder wall and pericholecystic fluid, and that you now have your diagnosis because of that, especially in the absence of stones, I think I think this provider did not really have a good understanding of the test characteristics of the test that he performed in terms of how nonspecific those findings can be.
So that's super helpful to know, and also really great information for us. So George, we're going to get back to you in just a second, but I wanted to start with Tim and then Nicole. I'm going to ask you guys the exact same question. You're now standing at the bedside. You have this ultrasound finding, but also you've just done a deep dive in the records and found that the patient in the past had this widened mediastinum that they had recommended, again, that possibly this could be from a ascending thoracic aortic dissection, right? So the question, Nicole, and then again, Tim, the exact same question to you. The question is, if you're at the bedside now, do you still send the patient over for the ultrasound? Do you order a CTA right at that point? Do you get an X-ray? And if it comes back normal, you feel reassured? Or is there some other thing that you would do? Nicole, why don't you go first?
So I feel sometimes the rate limiting step with bedside ultrasound is getting the ultrasound to the bedside. So if I'm already standing with the ultrasound and I'm in the right upper quadrant, I think my first move is I'm just going to scan my probe midline and just take a quick look at the aorta. I don't say that I know how to diagnose a dissection on an ultrasound, but I mean, at least I'm looking to make sure there's no AAA. I can quickly fan up and take a look at the heart. That's going to give me a lot of ultrasound. Most ER providers, regardless of your ultrasound background, can take a quick subxiphoid view of the heart. So that's going to be my very first step. I am thinking about a CTA at this point too. Probably chest x-ray is standing behind me getting ready to shoot, so I can have them do that right before we wheel the patient off.
Okay. So, Tim, what do you think? You are still sending the patient to a formal ultrasound in the right upper quadrant, like in this physician who is seeing this patient, like they did, or are you doing something different?
I think my formal ultrasound in this instance is going to be a CTA. I'm probably going to do the same as Nicole's, just kind of move that probe over a little bit, take a look at the aorta, realizing that it's going to be pretty specific. If I see a big dissection flap done, perfect. I'm going to start managing that patient while we get the definitive CTA for the surgeons. But if I don't see anything, that's not going to dissuade me from getting an actual CTA. And going back to Mike's point, really that gallbladder wall thickening and pericholecystic fluid, you'll see that a lot in heart failure, right? Anytime there's gallbladder edema, there's visceral edema, you'll see a lot of that swelling. And so that may also key me into, this guy is 60, he has some vascular risk factors, he has this widened mediastinum. Is there something else going on vascular or with the heart that I should be keeping an eye out for?
So, George, before we talked about wide and mediastinum and the differential for that, let's sort of flip this a little bit and think about the things specifically we'd see on a chest X-ray in a patient with a thoracic aortic dissection.
Sure. So obviously we've talked about wide and mediastinum. That's a big one. But one of the things that I kind of, before I get into it, really want to belabor is the chest X-ray is a poor test to rule out aortic dissection. So let's just get that out of the way. If you have an abnormal finding, you got to look for it. But if it's a normal chest X-ray, it does not rule out an aortic dissection. Now, a lot of times, a lot of emergency providers are looking for that wide and mediastinum, but there's a lot of other things that can cause an abnormal chest X-ray in a patient who has an aortic dissection. First one is the aortic knob, and we've all looked at chest X-rays and kind of know kind of the normal contour of what the heart's supposed to look like. And at the very top, that aortic knob, it should kind of bubble down before it comes into that left side of the heart border. If it goes from the top of the aorta straight down and almost like a triangle formation, that's a sign that there's probably something wrong with the aorta. Either it's widened in an aneurysm or there's a dissection that's going on. Then there's the difference in between the diameter of the ascending and descending aorta. And what you're probably going to notice is that the ascending aorta is going to be dilated. And where you'll see that is on the right heart border. If you see this kind of abnormal hump that I sometimes call a hill that's coming out of the right heart border, that's an abnormally enlarged ascending aorta. And more than likely, again, it's going to lead to either a diagnosis of an aortic aneurysm or an aortic dissection. If the aortic margin and at that very top, if it's blurred and kind of nondescript, that's also something that could be a sign or pointing towards an aortic dissection. And then they talk about effusions that are present, if there's a bilateral or unilateral pleural effusion. Usually that's due to leakage, or it can be due to pericardial tamponade. That can be a sign that there may be an aortic dissection as well. So those are the kind of the big findings that you would look for. And, you know, a lot, again, that's why I always look at my own images, look at my own chest X-rays. And when you've seen a number of chest X-rays, you kind of get used to what the heart is supposed to look like. And when you look at the aortic contour and it looks different, you should probably be doing, especially on the right clinical context, be doing some kind of advanced imaging of the aorta.
Awesome. So here's what happens is the patient, I'll just sort of switch the next set of questions. We already talked a little bit about POCUS for cholecystitis. So actually, before we find out what happens specifically next with the patient, let me first bring things back to Tim. It'd be easy if we could have just a D-dimer, and I'm guessing you said your ultrasound is the CTA. Is your D-dimer also the CTA?
Oh, I wish it were that easy. You know, historically, there's been a bunch of interest in finding a lab or something that we can do, that we can send the test and then avoid a CTA in these patients and say, you are so low risk that I don't even have to investigate it any further than doing a D-dimer. And there's been some studies, some small studies showing that maybe D-dimer has some promise, but at the end of the day, it probably doesn't. You know, those studies haven't really been validated in larger cohorts. Prospective studies are really hard to do in this patient population. And back in 2015, ACEP released the thoracic aortic dissection clinical policy that stated, in here I'll quote it, in patients with suspected non-traumatic thoracic aortic dissection, do not rely on D-dimer alone to exclude the diagnosis of aortic dissection. Furthermore, they said, in an attempt to identify patients at very low risk for acute non-traumatic thoracic aortic dissection, do not use existing clinical decision rules alone. The decision to pursue further workup for this should be at the discretion of the treating physician. So you really can't get away without using your clinical judgment. You can't send a D-dimer and comes back negative and rule it out.
And so this might be a nice time for me to interject just briefly that of the many medical legal cases that I reviewed, the thing that I find over and over and over again is lack of appropriate data gathering. And you think of a patient with chest pain, right? And you're thinking of maybe the big three, ACS, PE, and dissection, right? Well, you know, ACS, you're asking questions about exertion and diaphoresis, radiation, and questions about PE, maybe pleuritic aspect or unilateral pain or swelling of the legs, recent surgery, et cetera, all those hypercoagulable things. But it's amazing that oftentimes I don't see any questions asked about thoracic aortic dissection. Like George said earlier, the acuity of the onset, like a thunderclap, right? You know, the intense pain, the radiation through to the back, maybe those weird above and below diaphragm symptoms, or lack of an alternative explanation for the patient's symptoms. And it's really a shame that the history is not better because it's free, right? We're just sitting there and we have the opportunity to ask people about those types of the types of symptoms that they're having and to gather that appropriate data. So Mike, before I ask about the question about the EKG, I would just sort of bring it sort of home here is that probably the reason why we don't get burned by this more commonly is because it is so rare. So, you know, we might not do a really great history, but just sort of get lucky because we're looking for something that just doesn't happen that often. But even if we each see this, you know, 10 times during the course of a 30-year career, I mean, absolutely 100%, we have to make this diagnosis, at least when we have the opportunity to. So Mike, with that long talking your ear off explanation of things with the medical legal part, EKG, I assume that you are going to say the same thing George said about the chest X-ray, the same thing that Tim said about the D-dimer. We cannot use a EKG to rule out thoracic aortic dissection.
No, there isn't really a characteristic finding to rule it in, and there's nothing that the EKG can show you that will rule it out. A normal EKG that does nothing to even decrease the likelihood of a dissection. And the things that you're going to find that are abnormal with a dissection are really not specific to dissection. I mean, if they're dissecting into the coronaries, you could see a STEMI. Right? So that's certainly not specific to dissection. Most STEMIs are not due to dissection. There could be findings of ischemia. Most commonly, it's non-specific T-wave changes, those sorts of things. Depending which study you read, anywhere between 15 and 30% of these folks will have an abnormal EKG, which means that, well, about 70+% don't, right? But the abnormalities that are present are really not at all specific. I'm sorry, those percentages will have ischemic EKGs, but the findings are just not specific for dissection.
Okay, so Nicole, the last question as far as the diagnosis, then we're going to get into the real nitty gritty here with management of these aortic dissections. So we know, I'm sure all of us have heard the case of Jonathan Larson, the writer of the musical Rent, and he had a misdiagnosed thoracic aortic dissection. He went to 2 New York City hospitals, first time being diagnosed with food poisoning, second time with gastroenteritis. And then on preview night of the musical that turned out to be the longest running musical in the history of Broadway theater, he was unfortunately found dead in his apartment. And he had not only the thoracic aortic dissection, but it had dissected proximally and resulted in a huge pericardial effusion. So you don't really have to just sort of go through a list of 20 things that cause pericardial effusions, but give us some context when we see not only wide immediate sign, but maybe a enlarged heart, or based on an ultrasound, not just a chest X-ray, ultrasound showing that effusion. Where do we go from there?
So, type A dissections, about 50% of these people are going to have a pericardial effusion. So if you're having a pericardial effusion and any concern that this person might be dissecting looking at an old chest X-ray, then if you haven't done the CTA yet, you're taking a beeline to the CTA at that point. And unfortunately, up to, I think, 14 to 20% of these patients will actually end up getting cardiac tamponade. So it's a big deal with pericardial effusions, type A dissection specifically. Other things that could cause pericardial effusions, but not really applicable in this particular patient, obviously pericarditis. That's probably one of the more common ones we see. Any kind of malignancy, uremia, any kind of collagen vascular disorder. Also have any kind of idiopathic cause of pericarditis. But really, none of those seem to apply readily in this patient's case. I think that if we're seeing a pericardial effusion and we have a concern for dissection, that's really kind of those two marry well together.
And I'm guessing also the ones that you described are sort of a slower onset of this effusion, maybe gradually progressing to tamponade, whereas, of course, if you're acutely dissecting, you could get there very quickly, of course. So let's find out what happened here. The actual provider did eventually now, because they were, again, distracted, understandably so, by the pericholecystic fluid and maybe by the epigastric or presentation as opposed to the back pain presentation. But they said at 12:05 now, CT chest, abdomen, pelvis ordered for evaluation of left lower quadrant pain. Interestingly, they say not likely explained, sort of same like Pallaci, as you said, by acute cholecystitis. The 12 lead was not suggestive of ACS. They were going to add on a troponin test. Chest x-ray pending, interestingly enough, that hadn't yet been done. And so they get this CT scan. And also they say a cardiology consultation for pericardial effusion. The CT scan is read now at I think it's 1:20 in the morning, actually, because that's probably no, I'm sorry, 1:20 in the afternoon. Sorry, so that is correct. So an hour 20 later, Stanford type A dissection, and they say with aortic rupture and hemopericardium, mass effect upon the right ventricular free wall, concerning for tamponade, and the abdominal extension of the dissection involving the celiac axis trunk. Interestingly, marked gallbladder wall thickening, so maybe their ultrasound skills were actually better than we're giving them credit for here. So, George, what I want to do is sort of move us to the next level here, and wanted to think about, we now have gone through all this, we have made the diagnosis, the patient obviously is still alive here in front of us. What are the things that you do, top 5 or 10 things that you do to acutely manage a patient with a thoracic aortic dissection?
Absolutely. So the first and foremost thing that you have to do in this circumstance is you have to decrease the stress on the aortic wall. You have to decrease the stress on that intimal flap to make sure that you're not actually propagating a worsening of that intimal flap, tearing into the aorta. So you're going to do that by first managing the heart rate. And the way that you're classically going to do this is with a beta blocker. And what you're typically trying to do, not only if in terms of decreasing the heart rate, but also decreasing the reflex tachycardia that's going to result as a result of you decreasing the blood pressure, which is the next thing that you're going to do. So I usually start off with esmolol. It's my go-to. It's rapid on, rapid off, titrates very easily. I start them on the esmolol first to decrease their heart rate and decrease that DP over DT. And the way I like to think about the heart rate is that there's this jackhammer as their heart rate is in that 100, 110 phase, and it's pounding against that intimal flap. And so by slowing that jackhammer down, you're actually decreasing that pressure against the intimal flap. Then you're going to focus on the blood pressure. My typical go-to used to be nitroprusside. Nitroprusside has really kind of gone the way of the dodo bird now, because we have a lot better, more available and easily titratable blood pressure medications. So nicardipine is a great one. The problem with nicardipine being that it lasts a little bit longer than nitroprusside did. And so sometimes patients would get these watershed infarcts if we drop their blood pressure too low. They start to have stroke-like symptoms, and then we start to lower or titrate down the nicardipine, and it takes a little bit of time for that blood pressure to respond. But now we have Clevaprex or clovidipine that's out there, which is a great medication for this. It's rapid on, rapid off, very similar to esmolol. If a patient starts to show signs of watershed infarcts in the brain, you can actually start to titrate it down. You'll see immediate effects. The problem with clovidipine being that it's in that lipid emulsion that we see very typical with propofol. So I call it the milk of hypertensia, if you will. And it lowers the blood pressure very nicely. The goal blood pressure and heart rate in this circumstance, the heart rate's going to be, you want the heart rate to be around 60 to 70 beats per minute. And I try to keep it on the lower side, closer to the 60. And then I want that systolic blood pressure to be as low as possible if they were hypertensive when they came in. So I try to maintain perfusion to the brain, keep their mental status okay. So I try to aim for anywhere between 100, 110 to 120. So those are my goal blood pressure. And then a really prominent thing that we oftentimes forget about, we're so focused on blood pressure management, we're so focused on heart rate management that we forget about the fact that these patients are oftentimes writhing in agony. And so it's really, really important to treat their pain. Give them analgesia. I'm usually using things like morphine or fentanyl to help control their pain in a very rapid fashion, decrease that catecholamine surge to prevent that blood pressure and heart rate from coming back up just due to pain.
So, George, let me bring a listener question in here. This is Patricia, and so I'm interested in your thoughts. I'll just sort of summarize her question. We could probably all see it in the chat. Shocking that the patient isn't writhing around in pain, because oftentimes these patients present with this severe pain, and severe pain like you talked about before. And interestingly, the patient had been there 11 months previous. So, I mean, it's not like every single one of these patients dies either, right? So, give us like some insight, like what's going on here that the patient had a dissection, probably, and then 11 months later comes back and now is not writhing around in pain, even though he has a type A dissection.
So this is a really great question, and this kind of gets into the D-dimer question, is that sometimes patients can dissect and not die. They can have these chronic dissections where they dissect and their body kind of equilibrates. And so you don't want to say that they're getting used to the pain, but essentially they're not getting that tearing anymore. So those nerves that are innervating the areas where they're feeling that pain are not actually getting stimulated anymore. So they're not actually experiencing that pain. Additionally, any type of malperfusion, in most circumstances, if there was malperfusion, the patient obviously had worsened outcomes. But if they have any malperfusion to some other organs that then somehow get collateral circulation, reestablish blood flow to those areas, that pain may actually go away. So if they have a little bit of mesenteric ischemia or renal ischemia or lower extremity ischemia from that intimal flap going across those branch vessels coming off of the aorta, if it's not treated and they don't lose those organs as a result of that malperfusion, what ends up happening eventually is they'll reestablish kind of collateral circulation over time. And then again, those symptoms may go away and they will not be experiencing any pain anymore. So I've seen a number of patients with these kind of chronic aortic dissections. Oh, I had something, in my chest like 11 months ago, but I didn't come to the hospital for it. I just took some ibuprofen and I felt better. And then they come in and now they're either redissecting or something else is going on. We CT their chest and sure enough, there's that dissection. And it's kind of, fearful to look at when you're like, oh my gosh, what happened the last time? Why didn't you come to the hospital? You could have died. So
Tim, I want to bring things into you for just a second here because, we all think about patients that have that elevated blood pressure, and we have patients who have low blood pressure from sepsis and obviously a lot of different things. I had a patient, this is just last year, who was a adolescent, unfortunately, with Ehlers-Danlos syndrome and came in talking. And as actually George had talked about it with his University of Maryland panel that we were on just back last March, he actually presented with lower back pain, which then sort of started coming more cephalad as his, presentation. But he was there for, 8 minutes, 12 minutes, something like that, before he became profoundly hypotensive and unfortunately then went into arrest and unfortunately expired. So give us now, as opposed to esmolol and other type of drips that we can use for elevated blood pressure, where are we going if we now have a patient who has a blood pressure still talking, but maybe 60, 70, 80 with this type A dissection?
So if I have a known type A or a known dissection and then they become profoundly hypotensive, it's like purely figuring out why. It could be one of several things. So most concerning, do they actually have tamponade physiology? Did they dissect into the right coronary artery and now they have severe RV failure and cardiogenic shock? Did they rupture the aorta somewhere else and they're hemorrhaging out? Do they have an aortic valve acute insufficiency? Everything's going to be treated a little bit differently, right? Like you might take some volume off the right ventricular failure and give them some inotropy, but for the tamponade, you're giving volume to them, right? So everything's going to be a little bit different, but the core tenets are going to be the same. Figure out what's going on. Most of the time, that's going to be with your point of care ultrasound. And then after that, you're going to defend the map. If they need pressors, if they need fluid, however you need to get that mean arterial pressure up to perfuse as much of the coronaries and the rest of their body as possible, aim for that map of 65 and then ensure forward flow. If it's a cardiogenic shock or if it's acute aortic insufficiency, just get as much forward flow as you can while trying to temporize a patient, hopefully for the OR.
Let me give you a couple rubber meets the roads questions. Hypotensive fluids, 500 cc's, a liter, 2 liters, or do you go straight for blood? Obviously, peripheral dose pressors, if you don't yet have a line, we'd rather start those sooner rather than later. What are your thoughts on fluids?
I'll usually give, especially if I know that if I see that there's probably a tamponade, you're really driving that CVP up as much as possible, right? You have that pericardial effusion is just pushing, pushing, pushing. They need preload. So I'll give 500 cc's and then repeat the ultrasound. If they start getting worse, give a little bit more volume. I think we had a non-surgical candidate in the ICU, and she probably got about 4 liters in a night just to temporize her until we could figure out an OR plan. So you can give quite a lot of fluid. For pressors, peripheral pressors, totally fine, especially when you're figuring everything out. Give a unit of blood. It's not going to be the worst thing in the world for these folks, especially in the emergency department. And then worry about getting central line access later, getting an A line if you need it, that kind of thing.
So let me ask you this question for Shayla, then we're going to go to Nicole for a question here. So Shayla says, if there's concern for interaction of methamphetamine and morphine used for pain control, what would you give this patient for pain control?
That's a tough one. Some of the stuff that we typically will use that's opioid sparing probably won't be super helpful, right? Like your Tylenol, your NSAIDs are probably a no-go in this patient. If you're thinking about giving some pain dose ketamine, you can kind of talk about, do you think theoretically that you're going to increase their endogenous catecholamines and make things worse, right? That's kind of how ketamine keeps your blood pressure and your heart rate up. So I would probably end up giving a baby dose of fentanyl, like 25, 50 micrograms, and seeing how they do. And I think that you'll probably end up doing fentanyl or Dilaudid.
Okay, gotcha.
But
So
everybody
Nicole,
else, yeah.
so yeah, we can have everyone weigh in on that. In the interest of just a couple other quick questions, I want to make sure that we address, because we see these people at the bedside, and obviously all these things come up. So Nicole, managing, or I should say monitoring the blood pressure, would you put an A line in this patient? They're going to surgery, maybe they're going to surgery at your institution or being transferred, right? But whatever you're doing, you're going to want to have that done as soon as possible. Do you go straight for an A line? Do you just do frequent peripheral, automated cuff blood pressure cuffs? How do you monitor this patient?
Definitely want an A-line in the patient. This person's going for huge vascular surgery. That's a prolonged surgery. Someone's putting an A-line in this patient at some point, whether it's right before they go into the OR. I think it should be us in the ER, because you're going to have a continuous vital sign. Our heart rate is a continuous vital sign, and that's one of the main things we're controlling. The blood pressure is the second main thing you're controlling, so I think it should be a continuous vital sign. The one pearl I would say here, especially since you're interested in not under treating the blood pressure, check that classic, check your cuff pressure on both arms, because if you're dissecting into, let's say, your left subclavian, you may end up hypoperfusing the left side or having a lower blood pressure on one side than the other. So you want to put your A line in the side that has the highest pressure to make sure that you don't treat a falsely low blood pressure. But yeah, I'm definitely putting an A line.
As long as we have you on, Nicole, what are you doing for pain control? Well, which medicine and what dose?
I was going to say fentanyl. That was the first thing that came to mind.
Awesome. That's good. All right. So what I want to do is make sure that we have enough time. We have 7 minutes left. So let's say now this patient, we see what happens. The physician actually did do esmolol and interestingly nitroprusside, but I know that that's medicine we typically would not be using now, but that's what this specific physician did. Patient's neurologically intact. And they say the pericardiocentesis and intubation equipment is at the bedside, and they've consulted CT surgery, spoke with the ICU resident. This was in an institution that had residents. So first Mike and then to Tim, say the patient gets hypotensive. We've done an ultrasound. We know that they have a pericardial effusion, maybe even some tamponade, but they're going to surgery, maybe not in the next 5 minutes. What is the thing that causes you to go ahead and do that pericardiocentesis in the ED? And Mike, why don't you go first?
I'm trying to avoid the pericardiocentesis at all costs if I can. I mean, if the patient's dying from the tamponade, it's a different story. But the pericardiocentesis has actually been shown to worsen outcomes in dissection. And there's a few different theories as to why. And we can, in the interest of time, I can kind of skip through that. But the bottom line is it worsens outcomes. So the American Heart Association does recommend that if you have a patient that's unlikely to survive until you get to the OR, and doing multiple small volume pericardiocentesis, taking off maybe 10 cc's at a time, just enough to allow the heart to fill to maintain perfusion, but not enough to completely relieve the tamponade, is their recommendation and the way that I would play it. But that's only if the patient is crashing and isn't going to survive the surgery.
Okay. All right. So Tim, let me give you a different question, and then we'll get to some of our take-home points and get that QR code back up there for the CME. So intubation. This is a precarious situation of a hypotensive patient with an acute thoracic aortic dissection, especially if they have some tamponade physiology. What things are you doing if you don't have any choice but to intubate that patient? What are some things you're doing before you do the intubation, and what specifically are you giving medication-wise before the intubation?
So hopefully at this point, if they're hypotensive, you kind of have a sense of what's going on. You know, is this pure RV failure? Is this tamponade? Kind of where you at? And then you're resuscitating based on that. So hopefully in an ideal world, you have your A line in, you're treating the patient, you're giving them some volume, and then trying to use something hemodynamically neutral. You know, at this point, if they're hypotensive, I'll just induce them with ketamine and rocuronium, do RSI, and try to keep as low tidal volumes and as low PEEP as possible to really promote venous return to the heart, right? You don't want to increase your intrathoracic pressure, decrease your venous return, and cause the whole world to hurt. So I'll try as much as possible to just kind of go slow, little bits of ketamine, paralyze them, and then low vent settings.
Awesome. So why don't we wrap this all up? 45 seconds each. Nicole, would you like to go first? Then we'll say Mike, Tim, and George, you can bring everything home for all of us. So Nicole, 45 seconds that you'd like these 100 people to remember, myself included. I love learning from you when we see our next thoracic aortic dissection.
Looking through this literature just reminded me how much I need to think about aortic dissection. We have a lot of patients similar to this case. We have a high IVDU population in Camden, and I think there is something to be said about geographic bias. Every ER has your psych corner or your sober corner, and I think we have to keep our eyes open for these things a little bit more.
Awesome. Mike?
Okay, I'll give you a couple of quick ones on diagnosis and one quick one on treatment. Remember the concept of dissection being chest pain plus abdominal pain, chest pain plus neurologic deficit, and chest pain plus something else. Second, when you list those red flags for back pain, thoracic pain is always one of the red flags, and that's for a reason. Thoracic dissection is one of those reasons. There's others as well, cancers and things that can happen with thoracic pain. But patient with new onset thoracic pain, this is one of the reasons that is a red flag. And then in terms of treatment, I think George absolutely nailed it and hit it right on the head with the treatment. The one thing that I would add, just a little caveat from a little bit of experience, that when you're using esmolol to titrate the heart rate down, when you need to titrate it up, repeat the bolus. Because when I did not do that, I had trouble getting the heart rate under control. And when I started repeating the bolus with each titration up of the rate, esmolol was a much more effective medication for me. So repeat the bolus when you're titrating up the rate on esmolol.
Awesome. Tim, 30 seconds of things you'd like the listener to take home.
If you have a hypotensive patient with a type A dissection, there's only so many things that can be causing it. Do they have RV failure from an RCA STEMI? Did they rupture the aorta and they're bleeding out? Do they have aortic valve insufficiency? Do they have tamponade? Those are really the only things. And once you investigate those, treat them like you would any other hemorrhaging patient, any other patient with tamponade.
Awesome. George?
I'm just going to piggyback off of what Tim said. When you have a hypotensive patient, your friend is your ultrasound. Your ultrasound is going to be able to diagnose pretty much everything that can cause a patient to be hypotensive. So if you have a patient who comes in who has a dissection who goes hypotensive, it's not the drip that's causing the hypotension. Don't even think about it. Grab your ultrasound, rule out tamponade, look at the aortic root, make sure it's not dilated. And if none of those are the case and they have a very good squeeze on that RV, then it's rupture until proven otherwise. And those patients oftentimes do not make it to the OR. They're going to end up dying.
Thank you all so much, panelists. This has been a really, really good discussion of a patient we don't see commonly, but when we do see that patient, we absolutely need to know 100% what to do about it. Our next case will be the first Monday of March, as they are these first Mondays. 33-year-old man with abdominal pain who left against medical advice. And I will give you a little clue, is that the patient left another hospital and came into the hospital that I was working at, saw a different physician, but within 2 minutes of presenting by squad at the other hospital, at my hospital, that is, the patient went into full arrest. So we will find out more about that. Here's the QR code to get registered for the March 6th Bouncebacks. We are skipping April. That's because I will be doing some presenting out west. And if you want to look at this QR code again for the CME credit for tonight, here is the QR code if you missed it before. So again, thank you all so much. I hope we have been true to this hour of time that you've given us. And I hope, most importantly, that this hour of time will help us to take better care of our patients going forward. Again, thank you so much, Mike. Thank you, Tim. Thank you, George. Thank you, Nicole. And really, really appreciate it. I'll stick around for a few minutes, and folks that have questions on the chat, feel free to put those in, and maybe even the panelists will answer some of those questions. But thank you so much, and look forward to seeing everyone next month. Bye-bye, guys.
So far, I've only had to do pericardiocentesis in 2 patients with this problem. It went as expected.
As expected good or as expected bad? Probably bad, I'm guessing.
Bad. Yeah. The problem is like, we put in a kind of small drain the first time and it clotted off. We didn't flush it back. So you always got to flush it back. And then second time, it just, you get clot around the pericardium. So even though you're pulling off like 30, 40 cc's, there's still some clot. You get regional tamponade and then it's hard to get folks back.
Yeah.
Question for you. So I think in our ER, we just like have a standard one size fits all pericarditis. Where do you get your size up catheter? Like Guyver, a bigger?
Yeah. Yeah. So we have like the 8.3 French pericardiocentesis catheter. But where I was working, we ran out of them. So we ended up placing a regular triple lumen and using the distal port, which worked for a little bit, but then obviously clotted off because it's like just tiny, tiny. But the 8.3 drains work perfect.
Pull it out, or did you try to flush it?
We tried to flush it, and then we ended up having to pull it out, and it was actually a ventricular free wall rupture case. So it ended up being pretty bad.
Surprised you got to do any of that in case like those patients usually don't last very long, do they?
Yep.
Yeah, no, she was in arrest. She came in with Q waves anteriorly, a week of chest pain, and then arrested. Saw a big pericardial effusion, drained it, but
Yeah, I've done
Sabrina's
this
question.
probably
George.
I've probably done this about 5 or 6 times, which is way more than I've wanted to. What I've done traditionally, except for one time, used an art line, but and was actually successful in all of them but one. The art line didn't clot off, but the cardiothoracic surgeons were like, this is probably not going to work for that long. And I was like, well, that's why you take them to the OR as quickly as possible. And then one time we couldn't get an art line there fast enough, so I actually put a cordis in. It was the cordis that comes with the transvenous pacer. So it was like a 6 French cordis, and got that in really quickly, and it worked great.
Well, it's interesting you guys talk about like these patients and some of the successes and some of the failures. And of course, some of these, there's really just nothing we can do, obviously, when they present. But the times that I've been successful, and that's why I wanted to spend a bunch of time on the diagnosis with the beginning of this discussion, is because if you actually can suspect it and then make that diagnosis early, I'm not talking about this patient 11 months later, of course, right?
Sure.
But, you know, the patients that actually live, I think, are the ones that we can get to a little bit quicker and get them to the to the OR faster too. And I mean, if you're not able to do that, I mean, my institution, luckily, we do ascending aortic dissections, and I just actually had one a couple months ago, not myself, but a patient with one, and sent that patient straight up to the OR, and they lived and did great. However, if you're talking about transferring a patient and some of the extra time with that, man, that's going to be, unfortunately, the recipe for disaster, probably.
Yeah, I think a lot of it is the diagnosis. And then I know we talked about A lines earlier, but one thing, if you're like, I was so confused for a long time, like, oh, which side do I put in the A line? Which, you know, and if it's purely a thoracic dissection, then just like put in a femoral line. You know that it's the true lumen, and you're done.
Yep.
I saw your comment, and I was going to ask you if you found that there was a huge variability between doing a radial versus a fem line, and what was the, I mean, other than maybe the speed with which you can put in a femoral A line versus if you end up having any difficulty with the radial A line, but
No, typically it'll just be like anesthesia is going to want a whole bunch of stuff anyhow, because they're going to have a bunch of different stuff they do in the OR. So I'll just go in the groin and put in like either an HD cath for a ton of volume for them to give, or and an A line at the same time. And then it becomes really easy for me to do. This is more of like an ICU thing. I have like 5 patients and plenty of time.
I actually put a femoral art line in one time and had vascular surgery like rip me a new one because they were like, we're going to do a TVAR on this person. And you took the spot where I was going to go for the TVAR. I was like, dude, put a guide wire in it, take my A line out and do your TVAR over the guide wire. It is going right into the vessel. And they were like, well, okay, you're right.
you're welcome.
All right, and you're welcome.
Yeah, right.
It's gotta be okay, really. Like,
You
really,
have very little to do now.
right.
Well, guys, thank you again so much. Wow, this is great. We could like talk for another hour, but this is like the icing on the cake, having these personal stories at the end. So I'm sure we will all do some of these going forward because man, I learned so much for these, and what amount of expertise we have here. So thanks again, everyone, and for the folks that have been sticking around listening, it was a real treat for myself, and I'm sure for everyone here. So thanks again, guys, and I'll end the call, and we'll see y'all next time.
All right. Thanks,
Thank
Mike.
you guys. Thanks for having me.
All right. Thanks for having us.
Bye, guys.
Thanks, Mike.
Take care.